Good afternoon, everybody. I would take this opportunity to all welcome you for this International Breast Cancer Summit 2022. We could see few heads, some known and some unknown today. And certainly it's an afternoon session on a weekend, so it will be always a pleasure that everybody will be in free mind. But having said that, we know that there are 6 oncology meetings going on today in the city of Kolkata as of now. So that's a physical meeting what we are having. So having said that, that actually reflects the spirit of the what we call a revenge reunion, we can say that way, so far as an academic meeting is concerned. So that certainly boosts the morale of the organizers and of course the faculties, delegates who have pressed the button for registration. That's always a pleasure. Now, so far as this meeting is concerned, International Breast Cancer, this is our second of type meeting under the aegis of Apollo Hospital and Arroy, West Bengal. In fact, in 2021 April, in middle of COVID, we organized an international prostate cancer meeting. And you'll be surprised to know we had 150 delegates glued to the screen for a 3-hour session. So wish us good luck, hope we'll rock. And this, so far as agenda for our breast cancer meeting today is concerned, it is actually a very, very tight 8 hours schedule. So my only request to the experts, moderators, speakers, everybody for that matter, we'll try to respect the time because we have got international speakers with a different time zone. So time is something which needs to be taken care of, and I hope we are all matured by now, and we'll respect to that. So far as the sessions are concerned today, we have almost 5 sessions. We have divided it imaginary in form of early breast cancer, neoadjuvant treatment options and guidelines in breast cancer, locally advanced breast cancer, and metastatic breast cancer. And that is interspersed with some crisp panel discussions and hopefully some like dogfight style debates also we have. So let's see how we go on. So friends, my request to you that please look into the agenda. There are some very good talks and deliberations from different speakers and panel discussions. We have as a guest speaker Dr. Badwe, Director of Tata Hospital, and he'll be covering a topic on evolution of breast cancer in last 5 decades. We have Dr. Vijay Anand Reddy, Director Apollo Hospital, Hyderabad. He'll be covering on landscapes of radiotherapy in last few decades. And we also have virtually Dr. Duncan Whitley. He is the clinical coordinator for the Fast Forward trial. So he's excited and wants to enthuse and incite us about with the new kid in the block. That is what we are talking about, Fast Forward trial, the ultra short duration of radiotherapy. So we are all waiting for that. And finally, we also have many faces of TNBC, another pot boiler which is brewing hot. Sudeep Gupta, he's the director of ACTRAC, the research wing of Tata Memorial Hospital. He'll be unveiling a bit about the newer innovations which is happening in the tricky TNBC, that is triple negative breast cancer, and as a troubleshooter, how we can tame this disease. So with that, I welcome you all once again, and I would request Dr. Naziba to start the meeting from here. Thank you once again.
Thank you, sir. I would now like to invite the experts to preside over the next session. Dr. Suchanda Goswami, Senior Consultant in Radiation Oncology in Apollo Multispeciality Hospitals, Kolkata. Dr. Shubhashish Sarkar, Senior Consultant in Surgical Oncology at Bellevue Clinic. Dr. Saurav Ghosh, Professor and HOD, Surgical Oncology, Medical College, Kolkata.
Welcome everybody. Let me start by thanking the AROI and Apollo Hospitals for taking this wonderful initiative to have a focused single theme conference on breast cancer. The first session will be started off by Professor Diptendra Shorkar, who needs no introduction in front of such an august gathering. He is a Professor of Surgery in SSKM Hospital for many years and has a lot of original work on breast cancer, and he's one of the persons of the task forces of the ABSI who brought out the guidelines for management of breast cancer in India, which was the need of the hour at that time. So I'm sure he'll be informing us about the global cancer screening strategies and leave us with a clear message of its relevance or its applicability as far as India and West Bengal is concerned. Professor Shorkar, please.
Thank you, Shorab. And it's always a pleasure to be the opening batsman. The only thing is that when I used to go to Eden Gardens, I used to see only few people sitting in the crowd, and later on people start pouring in. But those who are not in the first few overs are going to miss the real fast bowling in the morning dews. So I'm sure I'm going to raise some controversies, and this talk as such is filled with controversies where we can argue, we can have at least 10 debates on every areas. So number one is the question that I'm going to ask myself, and the question that I'm going to ask all of you: is screening needed in developing countries? To answer this question, I have been doing a lot of homework, and if you look at the 35 years and the cutoff above that, it would be around 19 crore female in India. And if the likely incidence is 1 in every 28 to 30, that would mean that India expects an annual incidence of 6,59,391 cases. The actual reporting as per the last consensus was 1,43,000. So that means we are missing almost 1/3 of the breast cancer patients who are not been officially registered. I am taking you back to 1.5 decades back, Globocan data, and if you look at that, it states that roughly the high economic countries and the mid-low socioeconomic country, the distribution of cases will be 50-50. But if you actually look at the fact of underreporting, then actually the mid and the low socioeconomic countries have more load of breast cancer compared to the less populated but more affluent countries. But this is one thing, one important table that you must all understand, that in US, if the annual incidence is around 1,82,000 and the absolute death is 40,000, whereas in India it's 1,43,000 to 1,47,000 and the absolute death is 73,951. So roughly what happens is that the mortality is close to 50% in India, and that's probably because of the late presentation or at least the late initiation of treatment. And therefore, needless to say, yes, countries like India and the low and mid socioeconomic countries do need a training program. And therefore, there is no reason to believe that this lecture is not required, but I'm going to take you through what is essential and what is not. There are 3 options: breast self-examination, mammography, and clinical breast examination. Let us look at breast self-examination to begin with. There were 2 major trials, one from Russia, the other was from Shanghai. And both the trials actually put breast self-examination into a long bin basket. It's not required. That's what the conclusion. And therefore, there was a lot of frowning when you talk about breast self-examination being a tool. And it was criticized because of the over-diagnosis bias. But you have to reopen the studies and find that actually in those 2 countries, the median size of detection is 2.1 to 2.3. So that would mean in a country where the median size is 4.5, this is a good enough tool for early diagnosis. And even if you feel that there will be a large number of overdiagnosis bias by this tool, we have to understand that it makes a lady aware of their breast and also gives us the opportunity to treat. So it gives us the opportunity to at least to treat the benign breast diseases. Can I have the next slide, please? So therefore, the verdict is very clear. It does have a valid role in developing countries, not the way the affluent society will look at it, but it has its role definitely. The second talked about option is mammographic based screening, and we all know this data and the chart, and all of us have gone through that. And of course there are strong evidences, at least on paper, to suggest that mammographic screening helps. Of course there are 2 trials which actually have got an opinion which is against the reverse of what the rest of the globe would actually feel. But if we try to extrapolate this data on Indian subpopulation, we'll find that the median age being 46.7, of course because of the fat middle-aged group, you are going to miss the majority of cancer if you use mammography as a tool, which is more, and if you look at the evidences are strong after the age of 50 years. So it is not suitable according to the Indian age of presentation. In a country where 30 to 50% are locally advanced breast cancer, and the mean size in most of the studies ranges between 4 to 4.5 centimeter, you don't require mammograms to diagnose an early breast cancer. Above all, if you are able to ascertain in a single go the amount of money the United Kingdom spends on a mammographic screening program, and down there it comes to 1/4 of the Union Health budget of India. So of course, both from the views of the age, the large size, the financial unacceptability, it is not an acceptable tool. And if you have a drone photograph and you try to understand this is cricket and that's baseball, but from a drone photograph, both of them actually look the same, but it's a different ball game altogether. So what lessons we learn from the West? It, though on paper promised to have a reduction, this reduction actually didn't happen. And these are due to these problems. Number one is, this is an hypothetical thing that you are seeing. Now, if you have inception at A, and if you have a screening program which starts at B, and you look at that you are going to diagnose maybe more indolent cancers, and we are unsure with whether we are able to push the bar D. But we are sure about the fact that if you have triple negatives being treated by molecular targets, you are directly going to get a benefit. So in the era where therapeutics is coming up strongly, it makes for countries like us to invest more on therapeutics and get immediate reduction in population mortality than to spend the equal amount of money on a mammographic-based screening program, which might or might not give a reduction in mortality after 15 years. So what that the West have done is they have picked up more of the C's, and the A's were detected, and the A's died in 2 years' time. And probably they had more therapeutic intervention on A, and you picked up C, and so the trend of DCIS went up. So now there are 3 major trials that are happening in the West to make people understand that not all DCIS needs to be treated. So it was not being treated, and it is not being treated in this country. Now you have tons of 80% DCIS which you picked up by a mammographic screening method, and you are trying to generate an evidence to tell that most of them which are low risk DCIS should not be treated. But if you go back to the time machine, let's see what was reopen the file of Swedish 2-county trial. That was a hugely biased trial. The confounding bias was tremendous. Now there was one arm where the volunteers went to their home, they spoke about breast cancer, made them aware, took them for mammography, and the other arm, you never went into their house. But the trials that India generated, I'm going to show that, has actually removed this confounding bias. So the verdict is possibly we avoided the blunder unknowingly. Now we come to the third option, which is the clinical breast examination as a screening modality. Now we all know that this was published in the British Medical Journal last year during the pandemic, the old trial that was started by Indranil Mitra, which ran over 20 years. Now let us reopen the trial once again. Now look here, in this trial, both the intervention as well as the control group were made aware about the signs of breast cancer. And then in every 2 years, the female health workers actually did the clinical breast examination. And what was found after 20 years of prospective trial was there was 15% reduction in the premenopausal and 30% reduction in the postmenopausal age group. But far more important facts are evolving from the IARC trial, and that is done by Shankar Narayan. He started the trial, and I have had the opportunity to work with him in Bangladesh for quite a long time. And the last data that came out, the interim publication, shows that the CBE arm is picking up at least 18% or 18 out of 100,000 women which were early breast cancer, compared to the control group where it was 8. So therefore, it is generating an adequate evidence, and by 2023, the final verdict is going to come, which would be concordant with the Mumbai trial. So if we look at all the 5 options, this is an option that must go for all low and mid socioeconomic countries. So we are once again on the crossroads. Now we have a mammographic program which is going to give you a reduction of 25 to 29%, and the CBE, that's 20%, but the newer evidence is 30% reduction. So the question is, are they equally beneficial? The answer to the question is no. Now let us say why it is no. Now you have to look carefully that this is when the United Kingdom in 1987 started. The mean size was 2.7 centimeter, and it made sense that mammography was available at that point of time, and now the mean size of presentation has gone into the sub-centimeter level. But India is standing somewhere here. So if you start a CBE-based program, in another 15 years, hopefully you are going to come down to 2.7 centimeters. And by that time, if this breast meet happens after 10 years and mammography still exists as one of the tools for detection, then you can start. But at this point, it's complete waste of the hard-earned taxpayers' money. So in 2017, we were all there in the planning commission. We had multiple brainstorming meetings and to choose what was the best form of breast cancer screening, and before it was rolled out. And at that point of time, it was 3 yearly, then they expanded it to 5 yearly, of course, with some amount of political element in 100 districts. But this is the modification that we started in this state. Now this is the modified model that we have started, rolled out in 5 districts in West Bengal. The level 1 is, which is part of the National Non-Communicable Disease Program, where every house there is a door-to-door survey which is done by the ASHA workers, and we had trained almost 10,000 of them over a span of 6 months. In level 2, it goes to the community health officers, and there in the Shastha Surakha clinic, the clinical breast examination is being done. Once it is picked up by the ASHA workers, we have trained 450 of them, and all of them have been given a video to make them understand how it is being done. In level 3, we have started district breast clinics in 5 districts on 2nd of July, and we are generating data. We had trained 60 breast physicians who are doing this clinic, and then it is being, if they wish to do it there, it's fine, or else in the level 4 care, they are going to come to the comprehensive clinic at IPGMR. So what are the barriers? Barrier number 1 is quality assurance. We are struggling with that, and we are going to find a solution. The over referrals. Now look at this. This is the data from CBE which was generated in Odisha, and it goes straight to IARC, and Parthoda and I have actually gone into the whole thing and found that there were 20 lakh patients which were referred, which were officially, at least breast self-examination was done, and there was no referral, but the cutoff is at least 10% should be referred. So it means that proper breast self-examination or CBE has not been done. The second is you need a filter. And what is this filter? Now we are going to start this trial in November this year at our institute at IPGMR jointly with WHO, and there you see is a tool which is a handheld probe which is linked with a Bluetooth, which can be done. Initially we thought non-medical persons. Now we have eliminated that. We are starting it with the medical persons, non-radiologists, who are going to do a very simple test on the spot and generate a risk-based, that validation has been completed, and risk-based assessment of whether it's a benign or it's a malignant one. The second one is mRNA in the blood. Just give me 30 seconds. I think I deserve that because it was not there. Now, this is a very interesting publication from one of my friend called Bindu Salem, she is a fantastic lady who works in Coimbatore. And she actually generated this technique where mRNA is being taken in the blood and it's being studied. Now, we have given a modification and we are generating another study on this to make understand whether this is a valid one or not. A very interesting one again comes, we formed the Breast Global Hub. And this is Jill Darts, who is the immediate past president of the American Society. And we have had at least 5 meetings, and I met her in Las Vegas this year. And this is the tool she is recommended. What they are doing is they are taking the nipple duct fluid and looking at abnormal proteomic cells. And if you find that there is one, you are suspecting cancer. Of course, the question that comes to your mind is how every lady is going to generate a ductal lavage. They are having a small oxytocin patch which will be rubbed in the back in the post-auricular area, and immediately in 15 minutes ductal fluid is going to be generated. So that's where the Western world is actually going into. So the strategies therefore have to be different. Now I come to the end of the talk, and this is a very favorite slide of mine. These are from different 5 areas of the globe, and each trying to understand how the elephant is and describing it's in their own way. And this is how they would describe, and this is then what the elephant actually looks like. So if we blindly follow a model which is completely non-Indian, we are going to fail completely. Thank you very much.
Thank you, Dr. Sharkar, for this illuminating lecture. The session is open for a couple of questions. Anyone in the audience? We can take 1 or 2 questions. Maybe, Dr. Sharkar, you can answer. So, what would you say is the optimum strategy for population-based screening for West Bengal? Ultrasonography or clinical breast examination?
Clinical breast examination. Now, screening by classical definition means identifying cancers in the preclinical stage. We are not talking of identifying cancers in preclinical stage in India. We are talking about picking up cancers in the earliest symptomatic phase. And for that clinical breast examination, there is robust level 1 evidence, both an Indian trial and the WHO trial, to suggest this is the tool. And the model that we have started, and if it works out, that can be a good model for all developing countries.
When can we expect a publication on this data?
No, these 2 data are going to be published. Our main problem now is motivating people at the ground level to do this. I mean, it would take a lot of sweat to motivate a person to start a breast clinic. Of course, the government is helping and we are motivating them. Hopefully, it will take another 2 years time to come to a conclusive statement. The issue is not about the evidence. The issue is implementing it in the ground reality.
Professor Sharkar, I have a question.
Yeah.
So, sir, there is a difference in the demography of patients we find in Bengal, urban versus rural. So, in city like Kolkata, where we have a lot of women coming for self breast examination, and if we don't find anything clinically, should we just reassure them? Because sometimes they're very eager to do a test to find out whether they're okay or not.
Madam, opportunistic screening is not disappearing. I mean, if somebody wants an opportunity, that's called an opportunistic screening. Somebody wants, it's fine. Now, I'm going to show you, it's not there. We did another study on 100 patients with equal amount of representation from urban, rural, and extreme rural population. Right. We have found it conclusively that there is no link between socioeconomic status and educational level. A lady who is taking a bath in say, Fuldani village would pick up a small lump. That nothing to do with the education level. Again, a lady who is taking a bath in a jacuzzi also picks up a lump. What happens in the next level, there is an access delay. That's why we are talking about infrastructural building. The lady in Purulia will walk into the first available quack whom they think is a god. And we have seen all patients of gastric cancers taking pantoprazole for 5 months, then coming out when there is a melena. So the fault is not about ignorance. And we have also found that almost in every village there is 1 or 2 breast cancer reported. So they are already aware what we need to reach them. It's not a question of why they are not coming. They are ready to come, but we are not reaching them.
Thank you.
Okay, we thank Dr. Shorkar for his excellent talk. Now our next topic is by Dr. Sanjay Chatterjee. He is the senior consultant in TMC Kolkata. His topic is simultaneous integrated boost in breast RT. Dr. Sanjay Chatterjee, please.
Good afternoon, everyone. And Prosenjitda, thank you very much for inviting us, especially inviting me. You know, this has been around 2.5 years that haven't been to many physical meetings, and again, meeting with colleagues and friends for after such a long time physically is certainly something that I cherish. The topic you had chosen is a technical topic, but I'll try and give you all. I don't know how many of you are radiation oncologists, but I'll try and give you all a bit of a idea as to what this is and what is the clinical implication of this topic. So you know, time in general defines our existence, isn't it? If time is not there, we don't exist. And when we look at time, we always want to start on time. If Prosenjitda doesn't start on time, his meeting is going to be delayed. If you don't start on time, then you know you are late for some work. And this patient, this poor patient who's got breast cancer, who's coming over from whichever part of the world he or she is, you know, she also values time. And that is what we as clinical or radiation oncologists looked at. And we are lucky that, you know, we were able to crack the conundrum of time in the treatment of adjuvant breast cancer, in that 15 fractions of radiation have been conclusively proven now to be equivalent, or rather non-inferior, to 25 fractions of radiation even in the Indian population. So basically, someone who was having adjuvant breast radiotherapy over a period of 5 weeks has saved 2 weeks by getting the radiation in 15 fractions, or over 3 weeks. The question is, what about the new data that has come out from the West suggesting that fast forward 5-day fractionation is likely to be as good as the 15 fraction radiotherapy trial? Now, that is a bit of a question that we need to think about, because you know, these are the parameters of our patient, and I would entirely agree with Diptendra, who was the previous speaker, in that, you know, we have a different data set of patients. We have unscreened population, patients who are predominantly younger, higher grade 3 populations, significant proportion receiving neoadjuvant chemotherapy, and a significant proportion of them requiring regional radiotherapy, which were underrepresented in the fast-forward trials. Now you might say, but what about the current guidelines? You know, there are certain guidelines that have come during the pandemic, and those guidelines suggest that, you know, you could actually treat with 5 fractions. Friends, it was the time when the pandemic was rip-roaring. It was an emergency guideline, both by the WHO, it was an emergency guideline by the RCR group, and I would certainly not believe that without strong Indian data, we would change over as 5 fractions or 5 days treatment as standard. Now coming to the topic, boost. Well, whole breast radiotherapy, we talk about whole breast radiotherapy is important. But look at this. You know, there's something with radiation and breast cancer that gives effects which are really significant. A hazards ratio of 0.65, a relative 35% improvement in IBTR with just boosting the tumor bed after whole breast radiotherapy. And that is important. That is important in the bigger tumors after BCS. That is important in the younger patients. That is important irrespective of the grade of the tumor. But most importantly, if there is also DCIS, it's important. So boost mainly in younger patients, mainly in bigger tumors, mainly in patients who have associated DCIS. Now, how do we boost? I mean, there's no question that whether we have to boost. We have to boost after whole breast radiotherapy in breast conservation because there's a significant improvement in ipsilateral breast tumor recurrences. The question then is, how do we identify as a technician, as a radiation oncologist, how do we identify the tumor bed? And again, we go back to our surgeons and say, look, can you please mark the area with clips? If you mark the area with clips, we can see. If you don't mark the area with clips, God help the patient, it's anyone's guess, because with the mammoplastic procedures and other mobilizations that you do as breast surgeons, marking the tumor bed is essential because if we boost based on the scar you produce, we definitely boost the wrong area. So there's no doubt that if you give a tumor bed boost, you would enhance the in-breast tumor control rates in your patients. But that, again, if you look at time, will increase the treatment time. Now, let's try and see how we address this issue in Tata Medical Center. And I think, if you're interested, you can actually use this template in your center to try and see if it would fit your own idea of starting your simultaneous integrated boost protocols. So look, we first said, yes, if we have to boost, let us try and identify if electron boost is the way forward. And what we tried to do is we tried to calculate the tumor cavity. And we said, let's try and see if we have photon mini-tangent boost. By photon mini-tangent boost, we mean that, if you have this as a tumor cavity, if we can shape a small field which can give a mini-tangent boost, then is that any better using photon mini-tangent boost compared to electrons? And we then showed that, yes, electron boost is actually much more wider, less conformal, and likely to give you a slightly higher lung dose as well. Now that is important because when we are saying that the techniques we use are not optimal and there are better techniques like, changing over from electron-based boost to mini-tangent photon boost, then of course we have to move to that. And that's what we did in Tata Medical Center. We changed over to the photon mini-tangent boost and we said that, well, look, if we are changing over to photon mini-tangent boost, what next? We are still giving the patient those extra few days after the whole breast radiotherapy. I mentioned that, 15 treatments is 3 weeks of commitment from the patient. And you've got to remember these patients have had their surgery, their systemic therapies, and now their radiotherapy. They're really tired. So what do? Can we actually reduce their time even further? And that's when we tried thinking about the simultaneous integrated boost class solutions. So how did we go about it? Well, look, the mini-tangent boost was being delivered as a sequential boost. What if we can integrate the boost during the course of the whole breast radiotherapy, if we can simultaneously boost the tumor? And this is an example of that with the mini-tangent boosts versus, this is what we would identify as the tumor bed. And you can see we actually have 2 mini arcs. Now, the rule of thumb over here is that the arc should be so small that your exit dose does not go through the contralateral breast or the ipsilateral or contralateral lung. If your arc is big enough, then you will actually hit the contralateral breast and the contralateral lungs, and you are not going to do any benefit to your patient because they'll have more side effects in future. In doing that, what we did is we did an isodose coverage comparison, and this is on the left of your screen. You've got the conventional treatment of sequential boost, and this is the simultaneous integrated boost treatment. And you can see that the high dose isodoses are actually very well conformed to the tumor cavity compared to the photon mini-tangent boost. And if you remember, the electron mini-tangent boost was even worse. And this is, again, another comparison of the low-dose spillage, because that is one of the most important things to consider in adjuvant breast radiotherapy. You're giving treatment as an adjuvant. If you're talking about low-dose spillage, and if your boost is such that you are spilling your, with 1 gray, 2 grays, your entire lung is being spilled, then you're not doing any justice. And look again, conventional radiotherapy versus the simultaneous integrated boost, our doses were comparable. And that's when we said, okay, we've cracked it. Now, are we ready? And again, this is the statistical comparison. Now, and we published the class solution in the RCR journal. The question is, that was a dosimetric study. Are we ready to implement it? Now, to implement something something in real life patients, we thought that we need something close to a phase 1, phase 2 study. And that's what the HIPORT B study gave us. So basically it was a 26 gray in 5 fractions plus 6 gray simultaneous integrated boost in incurable breast cancer. So basically these patients had breast cancers already in them and they were symptomatic from the breast cancer. So we were treating them palliatively and we gave them radiotherapy with simultaneous integrated boost to the tumor. 2 reasons. One, to check whether dose escalation, because there was a previous study called the HIPORT A in which we gave a slightly lower dose to try and palliate the tumors. Now the SIB technique actually tried to see if we can implement the feasibility of implementing SIB in patients and assessing their toxicity and quality of life. We did in vivo dosimetry to confirm that we are delivering the right treatment, and that is important again if once you try and commission a new technique. And then we published and we said that yes, look, compared to whatever we do, our quality of life of our patients with SIB is maintained, and that they do not have grade 3 toxicity, which is most important because you don't want an inverse planned simultaneous boost to actually give them extra toxicity, skin toxicity. So that is when we realized that we are ready to use it now, not on the patients with bigger tumors, not on the incurable ones. So phase 1, phase 2 study is over. Let's try and see if we can now do it in the adjuvant setting. Whilst we were doing this, the group from Cambridge, Prosenjit's friend Charlotte Coles et al., they actually published on the IMPORT High study, which was again looking at a simultaneous integrated boost with 3 weeks of radiation. And they said that, yes, look, if you give this boost, similar to what I showed you, boost around the tumor bed, what is the morbidity? And they showed that, you have similar morbidity, 6% versus 7% grade 3 in duration at 5 years. And this is not just acute toxicity. This is 5 years morbidity. And they showed that, it is actually safe to give SIB in these patients. So that gave us the impetus, and that's what brings us to a study that I'm grateful that Shona and her funding has supported. Thank you very much, madam. And through the breast cancer research initiative, and we've also got some funding from the Lady Tata Trust on this study, and it's a multi-center study between Tata Medical Center, Christian Medical College Vellore, SGPJ Lucknow, and AIMS New Delhi. We went on with a daunting task of recruiting 2,100 patients, and as I was sitting there, Shona mentioned that, what about the progress report? Whilst I was sitting, I had the progress report. We have recruited 1,500 odd patients, and we've published, I'm pretty sure many of you have seen the publications on the acute toxicity, which suggests that, it is safe. What does the acute toxicity look at? It looks at all the skin toxicity, even within the SIB arm of these patients. So how did we get on to the dose fractionation? Well, Shantam and me, we sat together, we thought about the radiobiology of the study, and we thought for the different alpha betas that if for radiation oncologists this is, what would be the likely difference in the dose that we deliver, and this is how we went ahead with the endpoints of the study. Hopefully within a couple of years, you will have more data. In fact, this year you will have local control outcome data. Next year, possibly a clinical quality of life outcome data. And within the next 2-3 years, you should have the initial local control data with SIB published from your own country using a 5 fraction. If you look at the trial schema, again, it's a 5 fraction simultaneous integrated boost versus a 15 fraction simultaneous integrated boost in the HIPORT adjuvant study. With this, I rest my case. I think this is something we are really gearing up and looking forward to try and improve the patient journey. 5 treatments is all that you need, irrespective of whether you need boost or not, is what we would hypothesize. And we would say that this is what we can hopefully safely show within the HIPORT adjuvant trial. Thank you.
Thank you, Sanjay. So we can have 1 or 2 quick questions. Yeah, please.
Which problems? First is funding. Are you talking about problems for patients or problems for running the study?
Problems in carrying out this trial, particular trial.
No, it was, I must say, it was a lot of enthusiasm, and I really can't think of, I don't know if Shantam has come. He's supposed to come. I can't think of any problem running the hypoadjuvant study at all. It's a privilege. It's something, it's the first multicentric randomized controlled trial in breast cancer using radiation therapy in the country. It's looking at a futuristic technique, robust quality assurance, external peer review, data safety monitoring committee, which is internationally accredited. So I'm privileged to be part of this study. I don't think there was a problem. I mean, with anything there will be problems, but you know.
Quality assurance, that is
yes,
one of the most
we are doing external quality assurance in that, you know, each center is doing the quality assurance for the other center. And the quality assurance I talked about does include all this, you know, in vivo dosimetry, it does include film dosimetry. So all this has to be done. So class solutions have to be developed. So, you know, it's been a tremendous experience interacting with other centers, getting their planners to come up to speed, then getting on with the quality assurance and standardization. What I didn't show is, you know, there's even better quality assurance program that we are proposing called Suraksha through our Chaviri image bank, which I'm pretty sure you will all come to know very soon through a publication. It's again an external quality assurance process adapted from hypoadjuvant.
Yeah, I think one more question from there.
Yes, very nice presentation, Dr. Sanjay. Do you think that the late skin toxicity may be concerned while planning for the SIB and radiotherapy?
So, you know, if you're talking about late toxicity, yes, SIB is not giving any extra dose to the skin because you're off the skin. It's inverse planned, and you're just like I said, you know, this is what you're treating. You're just treating this over here, this cavity. Yeah, so you're not expecting more skin toxicity, more skin fibrosis. And if you look at the import high results, there was no extra skin toxicity either. So we're not concerned about extra skin toxicity over here. You can see that the skin is being spared over here. There's skin sparing because we're using megavoltage X-rays. So skin's been spared. Sorry?
VMAT, do you use VMAT in all your?
No. I mean, again, I must say that, you know, if I wasn't clear, SIB is a hybrid technique. It's a technique where you use, to treat the whole breast, you use tangential fields, and you use, you know, hybrid arcs to try and treat the tumor bed. Now, I would strongly recommend that you carry on this exercise of low dose conformity, high dose conformity index, homogeneity index in your patients, and then develop a class solution before you take on SIB. As of now, within the hypoadjuvant, it's Tata Medical Center only that's doing the simultaneous integrated boost. CMC Vellore, AIMS New Delhi, and MVCCRI has also joined us, and there was another center.
The problem is the identification, as you told. If there is no clip during the surgery, how do you identify?
If there is no clip, you know, God help the patient. If there is no clip, how do you boost? I mean, that's if even now we're talking about targeted therapy, immunotherapy in triple negative breast cancers, and if we can't give our patients a clip, then it's a lost game altogether. For a benefit I showed you, I mean, you're giving a 35% relative improvement in breast tumor control with boost. And if you don't know what to boost, it's such a lost opportunity.
I think we are really fighting with time.
Thank you so much.
So thank you, Sanjay. We could just continue, but we need to move on. So I would like to invite our next speaker, Dr. Shaina Dawood, Head of Medical Oncology and Head of Breast Cancer Program in Dubai Hospital, UAE. Her topic is Optimal Neoadjuvant Strategy in Triple Negative Breast Cancer.
After 2.5 years of being banned from India because of COVID, this is actually good to see everyone in person. So I was asked to talk about the optimal neoadjuvant strategy for triple negative breast cancer and I think this is a very, very important topic because now as community oncologists, I think it's unacceptable if you're not offering your patient with a stage 2 and above triple negative breast cancer neoadjuvant therapy. These are my disclosures, and if anyone wants to get in touch with me, you can scan the barcode and you can see all my social accounts. So as clinicians, as community oncologists, we have a straightforward, simplistic view of seeing our patients in the clinic. They either have triple-negative breast cancer, where all you can do is give chemotherapy, or hormone receptor-positive breast cancer, where endocrine therapy is the mainstay of therapy, or HER2-positive breast cancer, where anti-HER2 therapy is the mainstay. And today we're going to discuss about the various methodologies that we're using now to incorporate the optimal treatment strategy in a patient with triple-negative breast cancer in that neoadjuvant setting. Now, we know that over time, the prognostic outcome of patients with early-stage triple-negative breast cancer has certainly improved, and this is largely due to the fact that we are using neoadjuvant strategies, we're incorporating anthracyclines, we're incorporating taxanes as well, but more importantly, we've understood that when we give patients neoadjuvant therapy and then they go in for surgery, if they attain a pathological complete response, they do very, very well. Their prognostic outcome is at its best. But if they have residual disease, prognostic outcome is significantly impacted. And that is the reason why we have tried to have regimens that will improve pathological complete response rates. And we've tried to direct therapy based on residual disease in those patients who do not achieve a pathological complete response rate. So among patients with high-risk triple-negative breast cancer, could we improve prognostic outcome even further beyond using an anthracycline taxane-based regimen in that neoadjuvant setting? The first question was, could we add platinum-based therapy? Now, we do have a number of different trials that have actually looked at this question. We have had JEPR-6-2, CLGB40603, and then, of course, the latest brightness study, which have all shown that the minute you added a platinum in your neoadjuvant strategy, you were, in fact, significantly improving the pathological complete response rate, and you can see it on your slide over here. And we've also had meta-analysis that has shown that an increase in PCR rate from 36% to 52.1% is what we have achieved when adding carboplatin. However, the problem was that the addition of carboplatin was perceived to be associated with more toxicity and a higher discontinuation rate, and there was a complete lack of consensus as to whether we could add carboplatin or not. If you look at the NCCN guidelines, it's still not routinely approved as standard of care. But then again, we had the updated analysis from the Brightness trial last year at ESMO. This study looked at patients with triple-negative breast cancer, neoadjuvant setting, where patients were randomized to receive either chemotherapy alone or chemotherapy plus minus platinum plus minus a PARP inhibitor. I'll be focusing only on the platinum-based part of this study, and you can see that adding carboplatin to paclitaxel followed by AC, in fact, improved the event-free survival after a median follow-up of 4.5 years. It's very clear, although there was no improvement in overall survival. There were higher rates of hematological adverse events with the addition of carboplatin, but this did not compromise treatment delivery. And I can tell you in my practice, it's very hard for me to actually find a patient that's not completing that 12 weeks of taxane plus a platinum. Plus, there was no increased risk of MDS, AML, or other secondary malignancies. Now, what about incorporating the use of immunotherapy to increase those PCR rates? Well, we did see the results of the Keynote 522 trial that took patients with triple-negative breast cancer, again stage 2 to 3, randomizing them to receive a platinum-based chemotherapy alone or a platinum-based chemotherapy plus immunotherapy. This immunotherapy did go on to the adjuvant phase as well. Post-surgery, the primary endpoint of this trial was pathological complete response rate and event-free survival in the intent-to-treat population, with secondary endpoints of overall survival. Now, before we go into the results of the Keynote 522 trial, I just want to say that the control arm of the Keynote 522 trial that did not incorporate immunotherapy was platinum-based. That means Taxol, carboplatin, followed by AC. And when you see the little box I've put over here, you can see that the control arm, in terms of PCR rate, 51.2%, very similar to what we saw in the JAPR 6-dose CLGB 40603 trial and the Brightness trial, suggesting to us that we indeed need to add platinum. It's a cheap drug, it's not expensive, it increases your PCR rate. Now, in terms of the Keynote 522, you can see that with the minute you added immunotherapy to this platinum-based regimen, you can see that there was an improvement in PCR rate from 51% to 64.8% with a delta of 13.6%. And you can see that this improvement was irrespective of the PD-L1 status in the Keynote 522. Now, this year in the ESMO virtual plenary session, Peter Schmidt actually presented the event-free survival, which was the second primary endpoint of this study, and you can see that there was an absolute benefit of 7.7%, with translating into a 37% reduction in the risk of recurrence of disease the minute you added pembrolizumab to the platinum-based chemotherapy regimen. And although overall survival was not statistically significantly improved, there was a strong trend towards improvement in overall survival. Now, going forward, I think in patients with triple-negative breast cancer that are eligible for neoadjuvant therapy, there are a number of questions we're going to ask ourselves. Number one, is the increased pathological complete response observed responsible for the event-free survival benefit that we've seen? And is a PCR induced by chemotherapy the same as that we see with immunotherapy? Now, when you go back to the Keynote 522 trial, you can see that in patients who achieved a pathological complete response, almost a 95% event-free survival at 3 years. And in those patients who have residual disease, you can see that there was a benefit to adding that immunotherapy. So irrespective, you are seeing a benefit to addition of IO therapy. Is 1 year of adjuvant pembrolizumab in fact required for all patients? And are all PCRs in fact created equal? Well, when you go back to the JAPR-NUVO study, now the JAPR-NUVO trial was a phase 2 trial that also incorporated neoadjuvant immunotherapy in the form of durvalumab in patients who were getting neoadjuvant chemotherapy, but they did not give it in the adjuvant phase. They only gave it in the neoadjuvant phase. And you can see that there was an improvement to adding durvalumab in terms of invasive disease-free survival, distant disease-free survival, as well as overall survival. Now, when you looked specifically at those patients who achieved a pathological complete response, you can see in the durvalumab arm, irrespective of the IDFS, DDFS, or overall survival, brilliant 3-year rates in terms of IDFS, DDFS, and overall survival. Really asking the question, do we even need to give, in that PCR group, do we even need to give adjuvant immunotherapy? But as of now, the data is as it is, and we do need to continue our IO therapy in the adjuvant setting. But if a patient is unable to afford it, I would be very comfortable looking at the JAPR-NUVO study to say, look, you can stop after you've achieved a PCR. Now, we also know that not all pathological complete responses are the same. This was a very interesting study that was published last year, looking at patients with triple-negative breast cancer who had achieved a pathological complete response post-neoadjuvant therapy. You can see the 5-year DFS was approximately 86%. But when you substratify these patients based on their baseline clinical CPS-EG score, the higher that score, that means the higher the worse their clinical factors at presentation, you can see that their prognostic outcome was worse. So not all PCRs are in fact the same. For patients with residual disease, will we need to change therapy? Well, when you go back to the Keynote 522, again, those patients who had residual disease post-neoadjuvant pembro plus chemotherapy did better than those patients who did not receive neoadjuvant immunotherapy. You can see a 10.6% improvement in pathological complete response. But continuing that pembrolizumab in the adjuvant setting is an unknown factor. Will it further improve outcome? We simply do not know. But as it is, the Keynote 522 was designed with an adjuvant phase, and it's important to continue into the adjuvant phase as well. Now, when you compare it to some of the other adjuvant studies that have tried to direct therapy to residual disease, such as CREATE-X that used capecitabine, as well as JAPR-NUVO, where there was no adjuvant therapy, and then if you look at the EA1131 trial that was presented last year at ASCO that looked at capecitabine also in the adjuvant phase, you can see, apart from the outlier, which was the ECOG 1131 trial, all these regimens were doing very, very similarly. Should patients with node-negative disease receive immunotherapy? Because these are the patients that we would think would do better than patients with node-positive disease. Now, when you go back to Keynote 522, you can see that those patients who were positive as well as node-negative did actually very well. And if anything, the hazard ratio for patients with node-negative disease is better than the hazard ratio for patients with node-positive disease, again suggesting that both groups of patients are in fact benefiting from neoadjuvant IO therapy. Now, we cannot forget those patients who have a low ERPR expression, and that's the group of patients that we're always debating as to whether to treat them as triple negative or not in our MDTs. And you know, those patients who are ERPR low expression are those patients with an ER percentage of less than 10%. Well, we do know that these patients, and this comes from a large data set from our German colleagues and our Italian colleagues, has categorically shown that those patients with an ER negative versus those patients with an ER low HER2 negative disease, the time to distant recurrence, overall survival, and even pathological complete response is very, very similar to those patients with pure triple negative breast cancer. That means ER negative breast cancer, suggesting that the clinical behavior of patients with ER low disease is very similar to triple negative. And as of now, at least in my practice, if someone has an ER low disease, I will treat them as triple negative breast cancer, but this is an area of debate. And finally, what is the optimal neoadjuvant chemotherapy backbone for our patients with triple negative breast cancer? And the reason why I bring this question up is, should we be giving AC or EC in a dose-dense fashion in our patients? A very interesting meta-analysis that was presented by Elizabeth Mittendorf at the Miami Breast Cancer Conference earlier this year. She actually put all the data together, and this is a very busy slide, but essentially showing that in patients with triple-negative breast cancer, they're the ones that benefit the most from a dose-dense regimen. Now, this will have implications if you're planning to give dose-dense AC or EC. And you're going to be giving pembrolizumab as well, because you know pembrolizumab is given on a 3-weekly basis. So you could in fact shift from a Q3 weekly to a Q6 weekly regimen for your pembrolizumab and still incorporate dose-dense regimen, something that a lot of universities are doing in the US. However, in my practice, I will admit I'm still using it as per Keynote 522, where AC is given on a 3-weekly basis. Now, how could we potentially incorporate the use of a PARP inhibitor amongst patients with BRCA mutation positive disease to further improve prognostic outcome? And I think this question is very important because we now do have the results of the Olympia trial, which has shown you that in patients with a BRCA mutation positive disease who have residual disease post-neoadjuvant therapy or who have high-risk disease in the adjuvant setting, when you randomize them to receive either adjuvant olaparib or placebo, they have an improved IDFS. You can see a 3-year absolute improvement of 8.8%, a 3-year absolute improvement in DDFS of 7.1%, a strong trend towards improvement in overall survival with a 3-year absolute of 3.7%. Now, this is updated, and we did have the results earlier this year at the ESMO Virtual Plenary showing a clear-cut improvement in overall survival. Now, when you're putting it all together with CREATE-X, Keynote 522, you can see that, in fact, Olympia has the best 3-year event-free survival, really asking the question that in the presence of a BRCA mutation and residual disease, what is the best strategy in that adjuvant setting? Are you going to give adjuvant olaparib, capecitabine, pembrolizumab, or pembro plus olaparib in that triple-negative setting where patients have residual disease? I think there is no right or perfect answer, but in my mind, the Olympia study is the only one that has shown an overall survival benefit. So this is my last slide. A potential future algorithm in those patients with triple-negative breast cancer, stage 2 to stage 3. If you're going to give them immunotherapy or not, please do give them a platinum-based therapy in that neoadjuvant setting. If they achieve a pathological complete response and you've given them IO, you can continue IO, and you could potentially add olaparib if your patient had very, very high-risk features to begin with. In those patients with residual disease with a BRCA mutation, consider strongly using olaparib with, and if you have the means to be able to add it in terms of cost, you may consider adding IO therapy or using IO therapy alone. And then, of course, in the BRCA negative setting, you could think about using capecitabine with or without an IO therapy. So thank you very much. Right.
Thank you, Dr. Shaina, for finishing in time. I think we can have one question from the audience.
Guidelines of using adjuvant chemotherapy in HER2 positive setting.
HER2 positive. So in the HER2 positive, at least in my practice, anyone above a T1C, so T1C and above, I will give them neoadjuvant therapy, because if you look at the Catherine trial, they did include those patients, clinical T1C and above, because we know that if they have residual disease post-op, they'd be candidates for TDM1. However, T1C, I do tend to de-escalate therapy in terms of the type of chemotherapy I'm using. Most of these patients will be given 12 weeks of paclitaxel plus an anti-HER2 therapy in the form of trastuzumab. And higher than T1C, I do give them the whole gamut, usually the TRAIN-2 trial, where I'll give Taxol plus carboplatin, trastuzumab plus pertuzumab. And then, of course, if they've got residual disease, I will give them TDM1 in the adjuvant setting.
Thank you, Dr. Shaina.